Thanks, Dr. Forbes. So if we were to start, a typical patient that we would see on our unit would be perhaps a 43-year-old female who presented to emerge with a recent history of epigastric pain radiating to the back, accompanied with some nausea and vomiting. Her lab test results come back showing high liver enzymes with a bilirubin of 85, and her ultrasound of her abdomen shows a dilated common bile duct at 9 millimeters with a filling defect, making it highly suspicious of a stone. So she's referred to us for an ERCP. So part of our pre-ERCP nursing assessment would be, is she coming to us straight from emergency or another unit in the hospital? Or did she get discharged from emergency and is coming to us and as an outpatient? And this is important because we need to set up transportation for her either home or to her home unit. Goals of care designation, also important, just because if the procedure starts to go south, what kind of resuscitative measures will the team be employing? Will you be using full CPR, medical management, or just comfort measures? NPO status, has she been NPO from midnight of the day of the procedure, just to allow for the empty stomach and being able to visualize things appropriately? What are her comorbidities? Does she have hypertension, diabetes? And if so, is there a blood glucose level that we have on her? Heart, lung disease, sleep apnea. Is there a history of substance abuse as well that would affect the effectiveness of our sedation? Has she had previous surgeries, abdominal surgeries that may have fresh dressings or drains that we have to be careful of when we're positioning her on the fluoroscopic table? Has she had previous gastric surgeries that have altered her anatomy, which is handy to know before going into it? And has she had previous ERCPs, and why would we be repeating an ERCP that day? Any allergies to latex? Where our world now is mostly latex free, our extraction balloons remain as one of the few things that do have latex. We do have the option of using a non-latex balloon, but we don't have it as regular stock. So it's not as abundant as our regular balloons. Is there an X-ray or contrast, X-ray dye or contrast allergy as well? Usually that's because they've had it injected intravenously, and since we don't, we just inject it in the biliary tree, there isn't that systemic reaction, and we're usually okay with that. Does she have any bleeding disorders, hemophilia, von Willebrand's, any factor deficiencies or defects in platelet function? Is there a recent INR on her, and is it within normal range? Is she on any medications, particularly antiplatelets, anticoagulants, or insulin or hypoglycemics? So this slide just goes over some of the hold periods for the antiplatelets and anticoagulants that we may see. Oral anticoagulants are mainly held for 2 to 3 days, where warfarin is held for about 5 days, and we require an INR to be within normal levels. Otherwise, they can be given FFP or vitamin K to lower that level as well. Heparin infusions have to be stopped 4 to 6 hours prior to the procedure. Anyone on DVT prophylaxis or aspirin can continue without interrupting their therapy. And antiplatelets generally are held for 5 to 7 days. To continue on with the assessment, ensuring she has a functional IV for our sedation and administration is essential. Getting a baseline vital signs or pain level as well, just so we have a comparison post-procedure. And any pre-procedure medications that need to be administered. Will they need antibiotics, an Indocid suppository, just to just to lower the risk of post-ERCP pancreatitis, as Dr. Forbes had mentioned. And also for patients who had a high INR, did they receive FFP or vitamin K pre-procedure? Do they have any implanted devices like pacemakers or rods or screws in the spine? And this is important for us to know because we avoid placing a ground pad in the vicinity of pacemakers or surgically implanted hardware. Any dentures or partial plates need to be removed. Bras and ECG stickers also need to be removed just because they can interfere with our fluoroscopic view. Hearing aids, only the left one needs to be removed as the patient is laying on their left side. Keeping the right hearing aid is appropriate just so they're still able to hear us. And a last menstrual period for women of childbearing age and premenopausal women. This is for us to know to ensure that the patient is not pregnant. However, if it is deemed medically necessary for a pregnant patient to undergo an ERCP, we do require another consent form that is specific to diagnostic imaging to be signed to allow us the use of fluoroscopy. So a quick checklist for our pre-ERCP nursing assessment would be goals of care designation, NPO, INR, anticoagulants, antiplatelets, blood glucose if they're diabetic, any allergies, appropriate IV or CVC access that for our sedation administration, removal of dentures, partial plates, tongue or lip piercings as well, bras, ECG stickers, left hearing aid, getting an LMP for our applicable patients, and transportation home or return to sending hospital.